You know that feeling when you're driving a car that's maybe, let's say, seen better days?
Oh, yeah, I know that feeling well.
Right, you're cruising along, the radio's playing, everything seems totally fine, and then a little orange light flickers on the dashboard.
Yeah,
And it's not the engine is exploding light, it's just the check engine light.
the vague warning light, the one that basically everyone ignores.
Exactly. It's annoying, and you figure you can probably just ignore it for another 100 miles or so. But, deep down it's telling you something about the history of the car that you can't see under the hood.
That is actually a surprisingly accurate metaphor for what we are covering today.
Yeah, today we are getting up close and personal with your skin's check engine light. We are talking about a condition that is incredibly common, often ignored, and serves as a literal history book of every sunny day you've ever enjoyed.
Hmm.
We are doing a deep dive into actinic keratosis.
Also known as solar keratosis, just to keep things confusing for everyone.
Right. And to guide us through this, we have pulled together a really solid stack of research. We are anchoring this deep dive on a very comprehensive overview from Dr. Salem, which gives us the medical backbone, so the pathology, the definitions. But we're layering that with patient information leaflets from the British Association of Dermatologists.
The BAD.
Yep, the BAD and the Primary Care Dermatology Society, or PCDS.
Which I think is a great mix because Dr. Salem gives us the what is happening inside the cell perspective, but the BAD and PCDS give us the practical what does this actually mean for my Tuesday afternoon advice.
Exactly. So the mission today is simple. We want to help you identify these spots, specifically using something called the sandpaper test. Understand why they are considered a warning shot for cancer, and then navigate the surprisingly complex decision of whether to freeze them, cream them, or honestly just leave them alone.
And that last part, the decision to leave them alone, is where a lot of the real controversy lies.
We will definitely get to that debate. But let's start with the identification, because I think a lot of people might have this and just think it's dry skin. I mean, the name actinic keratosis, it sounds like a spell from Harry Potter.
It really does sound a bit magical, doesn't it? But Dr. Salem breaks it down perfectly in the overview. Actinic comes from Greek, meaning sunlight-induced. And keratosis refers to thickened skin. So literally, sun-thickened skin.
Okay, so it's not a zit and it's not a mole.
No, not at all. And this is where that sandpaper test comes in. This appears in Dr. Salem's notes and the PCDS guidelines, and honestly, it is the single most useful thing you will learn today. Often you will feel an actinic keratosis before you can clearly see it.
So your fingertips are the main diagnostic tool here.
You're washing your face, or maybe you're just absent-mindedly rubbing your forehead while reading an email, and you hit a patch that feels gritty, like fine-grade sandpaper.
Wow.
It's not smooth like a mole, it's rough. It literally catches the skin of your finger.
But when you actually go to look in the mirror, what are you seeing? Because the sources describe a bit of a chameleon.
Oh, they are total shapeshifters. Dr. Salem notes they can be pink, red, tan, or even just seen colored. They might have a white scale on top. The BAD leaflet actually uses the phrase warty layer.
Warty layer.
Mm.
That is delicious imagery. Thank you for that.
It's very charming, yes. But the size varies too, anywhere from a tiny dot up to 1 or 2 centimeters. And while they are usually painless, Dr. Salem notes, they can sometimes be itchy or tender. So if you have a rough spot that itches when you sweat, pay attention to it.
And location isn't random, right? We aren't finding these where the sun doesn't shine.
No, this is a direct result of UV exposure. So the high-risk zones are exactly where you'd expect: the face, forehead, ears, neck, the backs of the hands.
There was one specific location mentioned in Dr. Salem's overview and the BAD text that I think is a huge blind spot specifically for men.
The scalp.
The bald scalp.
It is a major issue. If you have lost your hair, you've lost your natural umbrella. The scalp sits horizontal to the sun. It just takes a beating all day. Dr. Salem and the BAD both highlight bald scalps as prime real estate for these lesions.
So if you're rocking the bald look, you really need to be doing the sandpaper test on top of your head.
Yeah.
Or ask a partner to do it for you.
Absolutely. It's actually one of the most common places dermatologists find them.
Okay, so we know what it is, sun-thickened skin that feels like sandpaper. But I want to dig into the why, because I think there is a big misconception that you get a really bad sunburn on vacation, and then boom, 2 weeks later, you get a keratosis.
It is not that linear at all. It's not about that one bad burn in Ibiza in 1998. It is the compilation album of your entire life outdoors.
Compilation album.
Yeah. Think of your skin as a bank account. Every single minute of sun exposure is a withdrawal. Dr. Salem emphasizes that this is caused by cumulative UV exposure. It's not just the peeling burns, it's every time you walked to the train station, every time you mowed the lawn, every time you sat by a bright window.
So the skin keeps the score.
The skin has a very long memory. The UV radiation damages the DNA in the skin cells, specifically the keratinocytes. Now, usually your body repairs that damage. It has built-in mechanisms to fix the DNA. But eventually, if the damage is constant over 40, 50, 60 years, the repair mechanisms just get completely overwhelmed.
And that's when the glitch happens.
Exactly. The cells start to mutate. They grow abnormally. That is what forms the rough patch. It is essentially a glitch in the skin's regeneration software caused by years of wear and tear.
So when you see that rough patch, you're looking at damage that might have actually started 20 years ago. The bill is finally coming due.
The bill always comes due.
Now, who's getting this bill? Dr. Salem lays out a specific profile, but looking at it, it feels like it could be almost anyone.
Well, statistically, the classic patient has what we call Celtic skin types: fair skin, blue eyes, red or blonde hair. The people who burn easily and tan poorly.
The lobster demographic.
Right, exactly. If you have less melanin, you have less natural protection against UV. But, and this is a really big, but lifestyle plays a massive role here. Outdoor workers like builders, farmers, and people with outdoor hobbies like golf or sailing. If you spend your life outside, you are accumulating damage regardless of how well you tan.
There's another group mentioned in the BAD and PCDS texts that we really need to highlight because the risk for them is significantly higher.
The immunosuppressed.
Why is that link so strong? Why does the immune system care about a rough patch on my hand?
Because your immune system isn't just fighting off the flu. It is constantly patrolling your body for abnormal cells, including precancerous skin cells, and destroying them before they become a problem.
That's the internal security guard.
Exactly. If you are on medication that suppresses the immune system, say, after an organ transplant or for a severe autoimmune condition, you have essentially taken the security guards off duty. The UV damage happens, but the body cannot clean up the mess as effectively.
So for those listeners, this isn't just a cosmetic annoyance, it's a serious medical monitoring issue.
Very serious. They need to be much more vigilant than the average person.
Now, speaking of serious, let's address the elephant in the room, the C word. I feel like whenever we talk about skin abnormalities, everyone just holds their breath. Dr. Salem addresses this head-on in the overview. Is actinic keratosis cancer?
No.
Just a flat no.
A flat no. Dr. Salem is very, very clear. It is not cancer.
Okay, exhale.
However,
And there's the inhale.
it is precancerous.
Okay, let's stop right there. What is the actual medical difference between precancerous and cancer? Because to a layperson, they sound pretty much the same.
It's all about invasion. Precancerous means the cells are abnormal, they are mutated, and they look weird under a microscope, but they haven't broken through the basement membrane of the skin. They haven't invaded deeper tissues or spread to other parts of the body. They are just sitting right there on the surface.
But they have aspirations.
They definitely have aspirations. If left unchecked, they have the potential to transform into squamous cell carcinoma, or SCC, which is a type of invasive skin cancer.
What are the odds here? If I have a spot, is it a coin flip?
No, much, much lower. For any single patch, the risk of it turning into cancer is actually quite small. The PCDS notes this very clearly. But here is the nuance. If you have actinic keratosis, you are statistically at a higher risk for all types of skin cancer compared to someone your age who has smooth skin.
Because the patch is a marker of total sun damage.
Exactly. It's the warning shot. It's your skin saying, hey, we have taken a beating here.
So how do we know if a patch is turning? Dr. Salem lists some red flags. If I'm doing my sandpaper test and I find a spot, what signals that I need to call the doctor today versus bringing it up at my next annual physical?
You are looking for change, rapid change. If the patch starts bleeding without being scratched, if it becomes ulcerated, meaning it's an open sore that just won't heal, if it becomes painful.
And shape, what about the shape?
Yes, if it develops into a lump. Actinic keratosis is usually flat or scaly. If it grows a distinct lump or a nodule that is a major alarm bell, that suggests it might be transitioning into SCC.
Okay, so bleeding, growing pain lump? Memorize those.
Yeah.
Now let's assume I've gone to the GP, they've looked at it, maybe done a biopsy if they're unsure, and they've confirmed it is actinic keratosis. Now we face what the PCDS calls the question of to treat or not to treat.
This is fascinating, isn't it? It feels so counterintuitive.
It really does. Because in my head, if something is labeled precancerous, you cut it out. immediately. You don't take it out to dinner. But the PCDS suggests that's not always the best move.
It's not. They point out that up to 25% of these lesions actually resolve without any treatment at all. They just disappear.
The body finally wakes up and clears them.
Exactly. The immune system finally spots the intruder and clears it out. So for a low-risk patient, maybe an elderly person with just 1 or 2 small spots that aren't bothering them, a watch-and-wait approach is perfectly valid medicine. You don't always need to go to war.
But for those who do need to go to war, maybe they have a lot of them, or they are young, or they just hate the feeling of sandpaper on their face. We have weapons.
We do. And they range from the very simple to the pretty intense.
Let's run through the arsenal. Dr. Salem and the BAD guidelines lay out a few pathways. The most famous one is probably the freeze.
Cryotherapy. Liquid nitrogen.
Is this a pleasant experience?
Not particularly, no, it stings. Dr. Salem warns it can be quite painful during the procedure. It works by essentially frostbiting the abnormal cells so they die, scab over, and fall off. But there is a downside that I think people really need to be aware of, especially if it's on their face.
A scar?
It can leave a hypopigmented spot, a pale white mark. So you trade a rough red patch for a smooth white patch. If you have darker skin or you tan easily, that white spot can be quite permanent and very visible.
Okay, so freezing is good for maybe one distinct spot.
Yeah.
But what if you have that field change concept? What if your whole forehead feels like gritty pavement? You can't freeze the whole forehead.
No, you look like a Dalmatian. For that scenario where there is a large area involved, we use topical creams. Dr. Salem lists drugs like 5-fluorouracil, which is often sold as Efudix, imiquimod, or diclofenac.
These are chemotherapy creams, essentially.
In a way, yes. 5-fluorouracil is a topical chemotherapy agent. You apply it at home for a few weeks. But this leads us to what I call the treatment paradox, which the PCDS highlights very clearly.
The paradox being?
For the treatment to work, it has to make you look absolutely terrible first.
Wait, explain that. I use the cream to fix the spot, but it makes me look worse.
Yes. These creams work by attacking the abnormal cells and stimulating a massive immune response. That causes inflammation, redness, crusting, scabbing.
So your face looks like it's been attacked by bees.
Or that you've face planted directly into gravel. The PCDS specifically lists flu-like symptoms and significant discomfort as side effects. But, and this is the crucial part that patients really struggle with, they say this redness indicates the treatment is working.
That is psychologically so tough. You're applying a cream to fix a spot.
Yeah.
Your face is basically melting off, and you just have to keep applying it.
It takes a lot of reassurance. Patients often call their doctors in a complete panic saying, I'm having a reaction, it's getting worse. And the doctor has to cheerfully say, great, that means we're killing the bad cells, keep going.
This leads to the most practical, real-world advice in the entire stack, which comes from the PCDS.
I love this advice. It is so human.
Do not start these creams before an important social event.
Simple but vital. Do not start your Efudix course 2 weeks before your daughter's wedding. Do not start it before a job interview. You will look alarming in the photos. You have to plan your treatment window around your social calendar.
It's basically forced social downtime.
Exactly. You need a few weeks where you are totally okay with looking a bit rough.
Are there options for people who can't afford the downtime or the white spots from freezing?
There is photodynamic therapy, or PDT.
That sounds very sci-fi.
It's pretty cool, actually. They put a cream on the lesion that makes the abnormal cells hypersensitive to light. Then they blast it with a specific wavelength of red light. It kills the cells. It's effective, usually done in a hospital, but again, Dr. Salem notes it can be painful during the process.
And for the stubborn ones.
Yeah.
The ones that just won't go away no matter what.
We go back to the classics. Surgery. Curettage, which is scraping it off with a sharp spoon-like instrument, or a full excision cutting it out. This allows for a biopsy, so if they are really worried about cancer, this is the definitive route.
Okay, so let's say we have gone through the war, we've frozen it, creamed it or scraped it, the spot is gone, my skin is smooth again. Can I go back to the tanning bed?
Absolutely not. And Dr. Salem is emphatic about this point. Treating the spot doesn't cure the damage.
The damage is in the DNA.
Correct. Sun protection is the only way to prevent new lesions from forming. The factor your skin is still damaged. If you keep adding UV radiation, you are just fueling the production line for more keratosis.
So we need to lock down the prevention strategy. What are the non-negotiables from our sources?
Dr. Salem and the BAD completely agree on this, SPF 30 or higher. But you also have to look for the star rating. You want 4 or 5 stars for UVA protection.
And I learned something new from the notes about timing. I think I have been doing this wrong my entire life.
The 15-minute rule?
Yeah. I usually just spray it on as I'm walking out the door.
Most people do, but you have to apply sunscreen 15 minutes before you go out. It needs time to bind to the skin to form that protective film. If you're applying it while you're standing on the beach, you have already missed the window. You are actively getting burned while you apply it.
And reapply every 2 hours.
Every 2 hours religiously, or immediately after swimming or heavy sweating.
Now, I want to touch on a nuance here that the PCDS and BAD brought up, which I think is really important for a balanced view, the vitamin D issue.
Right. This comes up all the time in dermatology.
Because if I'm covered head to toe wearing a wide brim hat and slathered in SPF 50, am I going to give myself a deficiency? We need vitamin D for our bones.
It is a legitimate medical concern. We absolutely need vitamin D. And the dermatologists acknowledge that strict sun avoidance can lead to a deficiency.
So what's the solution? Do we risk the skin cancer just to get strong bones?
No, that is a false dichotomy. The BAD advises checking your vitamin D levels. If you are low, don't try to fix it by frying your skin. Take a supplement.
Just pop a pill.
Exactly. They suggest 10 to 25 micrograms of vitamin D3 per day. Or eat oily fish and eggs. Use your diet, not your skin, as the primary source.
That makes a lot of sense. Don't use a damaged solar panel to generate energy if you can just plug into the wall.
That is a brilliant analogy. Yes, exactly.
Finally, routine. We can't just rely on the doctor to find these once a year.
No. Monthly skin checks are vital.
Hmm.
If you have a history of actinic keratosis, you are officially a skin-aware person now. You need to check your face or your hands, and yes, check your bald spots.
So to summarize what we've learned today, actinic keratosis is common. It feels like sandpaper. It's a check engine light from your past self about total sun damage. It's not cancer, but it's a cousin of cancer that you do not want to ignore.
And importantly, it is manageable. You have control over it.
I want to leave our listeners with a final thought, something to mull over on their own. We talked about treating the specific spot, the weed in the garden, so to speak. But Dr. Salem and the other sources hint at this concept of field change.
This is honestly the most profound takeaway for me. When you see one actinic keratosis, you're only looking at the tip of the iceberg. The skin around that lesion, the skin that looks totally normal to your naked eye, often has the exact same genetic damage deep down in the cells. It just hasn't surfaced yet.
That is scary, but also kind of empowering.
It explains why those intense creams we talked about are so remarkably effective. When you apply that cream to your whole forehead and the whole forehead turns red, not just the spot you knew about, that's not a mistake. That is the medicine revealing the hidden damage.
You aren't just treating the spot you can see right now. You're actually treating the spots that were going to appear next year or the year after.
You are treating the soil, not just the weed.
That is a really powerful reframing. It's not just removing a blemish, it's resetting the clock on your skin's overall health.
It really is. It is preventative maintenance for your future self.
Well, on that note, I'm going to go apply some sunscreen.
Wait 15 minutes before you go outside.
I will sit in the hallway for 15 minutes, I promise. Thank you, everyone, for listening to this deep dive. Go perform the sandpaper test, check your partner's bald spot, and we will see you next time.
Stay safe out there.